Okay, good morning. I'm going to get started because this is a large topic to cover in 25 minutes. And I'm going to start with non-invasive ventilation and finish with high flow nasal cannula for the inverse of the question. Yep, can people in the back hear me okay? Microphone's working, excellent. I got some thumbs up. And the slides are working back there as well? Perfect. All right, so my disclosures, in the past 2 years I've received funding for speaking or consultation, but nothing related to this topic. Now, if you do a PubMed search on non-invasive ventilation, you'll see that the publications per year have sort of skyrocketed. And I've heard, it's funny now when you hear it, but Dr. Bouchard's been referred to as the godfather of non-invasive ventilation. This change in a drastic publication sort of started around the time that this paper was published, showing a benefit for non-invasive ventilation, so strapping a mask to a patient's face and connecting them to a ventilator, an ICU ventilator, lowering intubation and lowering mortality rates and hospital length of stay in patients with COPD. Now, the goals of respiratory support when doing this is to try and reduce the work of breathing and hopefully their respiratory rate, provide supplemental oxygen when needed, optimize the patient comfort and tolerance of therapy, and perhaps protect the lung. And I put a question mark because this is not often discussed in the literature related to non-invasive ventilation, but I'll describe some conditions where this may be important. Now, I was going to have the Menti thing, but I'm just going to ask a question. So here's a scenario. You have a patient with acute hypoxemic respiratory failure receiving non-invasive ventilation. After 1 hour, these are the following settings: an IPAP of 16, an EPAP of 10, which gives them a pressure support of 6 centimeters of water. The FiO2 is set at 0.5. The respiratory rate is 30, patient's respiratory rate. That's their ABG there. And their heart rate's 124 and the GCS is 13. So with a show of hands, how many people would adjust the ventilator settings or the non-invasive settings? Nobody? Okay. How many people would consider intubation? How many people would not consider intubation? Okay, interesting. We'll see if you can guess the right answer after I get to the guidelines. By the way, this patient's PF ratio, I didn't see anybody bust out a calculator, but their PF ratio is 140. Your patient was extubated at 8 o'clock in the morning after passing a 1 hour SBT without any complications. At 6 o'clock later that day, the patient goes into acute respiratory failure with stats of 88% despite switching to high flow nasal cannula with FiO2. Would you increase FiO2, start BiPAP, or re-intubate? Who would start BiPAP? Who would simply increase FiO2? Who would re-intubate? Some people have read the guidelines. All right, non-invasive ventilation interface options. So there are a number of options out there that basically go from covering the nose and just gradually covering the entire head. So you have a number of different options out there. I'll briefly mention the helmet a little bit later, but basically you can decide to cover as much of the face as you want. In terms of settings, this comes down to what type of device you're using. If you're using the, for example, the V60 ventilator or the BiPAP Vision, for those that have been around longer, you may have to set an inspiratory pressure, so an IPAP, and an expiratory pressure, an EPAP. Now, if you're using a ventilator, an ICU ventilator, or some other non-invasive device, you may have to set the level of support. And this graphic just shows you the difference between the supports. So if you're setting the support level, that's how much support's given on top of the expiratory pressure, versus if you're setting the inspiratory pressure, it's the difference between those two is what the patient's getting. This is important for understanding what exactly you're delivering to your patient. Now, there are other settings, including mode, respiratory rate. Rise time, again, is how fast the ventilator pressurizes the breath. And then the inspiratory time is how long the breath will last if a respiratory rate or a mandatory breath is delivered. And this is more specific to the standalone devices that use what's called a spontaneous timed mode. And it's the most common mode used in sort of the devices like the V60 or the V680 if you have one of those. Now, what's important to understand, and I'll discuss this again in the workshop later, the respiratory rate should not be set close to the patient's own respiratory rate. These devices are spontaneous timed. What does that mean? It will only give a mandatory breath if the patient is not breathing above your set rate. So for example, if you set the rate at 10, the patient has 6 seconds before they take another breath in and the machine will not intervene. And every time they take a breath, they'll get the support. But if you set the rate at 20, for example, they have to take a breath every 3 seconds or else the machine's going to kick in and give it to them. So if you set it too close to their own inspiratory rate, you're going to get asynchrony with the patient. Now, leak compensation is something that's mandatory on ventilators now if you want to deliver non-invasive ventilation. It's not often something you can adjust. Some ventilators may allow you to do this, but it just to be considered when you're looking at purchasing equipment to make sure that the leak compensation is considered. Now, in terms of settings, what's interesting is the expiratory pressure provided during non-invasive ventilation in the literature ranges between 5 and 10 centimeters of water, not higher. You may find 12 used in some studies where they're just using CPAP, but traditionally nothing higher than 10. What's the number one reason why? Leaks. As you increase expiratory pressure, and I'm going to victimize somebody later in my workshop, as you increase expiratory pressure, your leak worsens. Okay, this is important. So if you're trying to provide evidence-based practice and you're setting patients on, let's say, EPAPs of 12 or 14 and then inspiratory pressure on top of that, giving a support of 6, you're not actually following what's been done in any of the RCTs. So this is potentially problematic as tolerance of the interface becomes less and less as you use higher pressures. So if they're failing, it could be due to lack of tolerance of therapy. Now, IPAP is usually titrated based on the amount of support you want to deliver to the patient, lowering their dyspnea, and it has been shown to be able to do this, but you have to consider if the patient's respiratory drive is not decreasing while you do this, you may be running into issues. And this is a great graphic by Dr. Slutsky, published in the New England Journal of Medicine, talking about ventilator-induced lung injury. And yes, indeed, on non-invasive ventilation, even if the alveolar pressure that's reached to the patient is only 10 centimeters of water, if the patient's making a significant drive, so a negative 15 centimeter drive in pleural pressure, they could be reaching transpulmonary pressures close to 25 centimeters of water, which is likely injurious, and this patient may be causing some of their own injury. Now, we do have guidelines for practicing non-invasive ventilation, and I'm not going to review the ones from 2011 published by the Canadian Critical Care Trials Group. I'm going to focus more on the more current guidelines published just last year as a combined effort from the European Respiratory Society and the American Thoracic Society. And there's a large list of clinical indications for non-invasive ventilation. I'm going to quickly run through these. Of course, hypercapnic COPD patients and cardiogenic pulmonary edema still has very strong evidence for the use of non-invasive ventilation as a first-line therapy. I think probably everybody in the room hopefully knows that, and this is the go-to for that. Where they recommend against, and this is important, patients with COPD that do not have associated acidosis, so the pH is above 7.35. It is not recommended to deliver BiPAP in these patients. Also, post-extubation respiratory failure. So for the people that said they would re-intubate that patient in this scenario, good for you. I can tell you it's probably not often done clinically. People will always try to go for the non-invasive option. And if you are 100% certain that what the problem with your patient that's failing extubation, less than 12 hours later, if you know exactly what the problem is and it's immediately reversible, then perhaps that's the right option, but really there's a potential for harm there. So they recommend against doing that. Where there are recommendations are consistent with the previous guidelines with a couple of extra patient populations. But immunocompromised patients, and I'm going to talk a bit more about this later because there's new data suggesting perhaps this may not be the best option, but it's still better than invasively ventilating them probably. But post-operative patients, patients with palliative that are considered palliative, trauma patients, post-extubation and high-risk patients. So to prevent respiratory failure or post-extubation failure, this is important. Not the patient that was extubated to oxygen therapy and then failed hours later. This is going direct from extubation to BiPAP to prevent failure. There's evidence for this and they recommend doing it. And weaning in hypercapnic patients. So these are patients that may not have met full criteria for extubation based on the respiratory rate or tidal volume, but they're on low enough settings. There's evidence to support extubating them to non-invasive ventilation. Where they'd have no recommendations are in patients with asthma, pandemic viral illness. They just weren't going to touch that with a 10-foot pole. And de novo respiratory failure. So I want to ask the room, a show of hands, how many people, and please be honest, have no idea what de novo respiratory failure is? Thank you for being honest. There's probably a few people there's like, I'm not putting my hand up because my colleagues might not want your colleagues to know. But de novo respiratory failure is usually referred to as de novo hypoxemic respiratory failure. It's basically respiratory failure in the absence of underlying chronic lung or cardiac disease, okay? So it's patients that don't have COPD or cardiogenic pulmonary edema that go into hypoxemic failure, so they don't have a chronic condition. This is typically what it's referring to. Now, How do you distinguish this in clinical trials? So back when the first, well, not the first, but that major study published in New England Journal of Medicine within the same year published in Chest, looking at non-invasive ventilation in patients that are hypercarbic, there's a clear benefit for lowering intubation rates, length of ICU stay, and ICU mortality. However, in patients without hypercarbia, there did not seem to be this benefit. Now, this almost 10 years later was discussed in a systematic review showing that in hypoxemic patients, the effectiveness varies among different populations, and the literature does not support the routine use of non-invasive ventilation in all patients with acute hypoxemic respiratory failure. This is back in 2004, and the clinical guidelines, published 15, I'm doing my horrible math here, 14 or 13 years later, still do not support use of non-invasive ventilation in hypoxemic failure. Now, the key word here is in all patients, okay? Basically, there are multiple etiologies for hypoxemic failure, and a generalized approach to, oh, my patient's hypoxic, I should give them non-invasive, is not recommended. However, if you look out in clinical practice, including your own clinical site, you may find that it's the wild west of non-invasive ventilation. There are likely many patients being managed with BiPAP that meet the criteria for de novo hypoxemic respiratory failure. And I'm going to discuss risk factors for these patients failing non-invasive ventilation that I think everyone should be very aware of, so that if you see these patients are being managed or started on BiPAP to avoid intubation, that you're clearly and specifically looking at risk criteria so that you don't potentially cause higher harm or more increased harm. So for example, this is a published paper in 2006 by Demoule in intensive care medicine. And they looked at patients that when non-invasive ventilation was given for de novo hypoxemic or for respiratory failure, success was great. So if they were successful, there was a reduced mortality risk. So that's a good thing. However, in patients without chronic lung disease, you can see in the non-invasive failure, the cursor works here, if they failed non-invasive ventilation in the absence of chronic lung or heart disease, these patients had an increased risk for mortality. The number one, or one of the major causes of de novo hypoxemic respiratory failure, pneumonia. How many have treated a patient with pneumonia with BiPAP? I'll put my hands up. So earlier studies are conflicting, and this is one of the reasons why, I remember in school when I was training to be a respiratory therapist, I was told that BiPAPing pneumonia patients was like giving them a curse. And then you start reading papers and it's like, well, in this paper, it seemed to be okay. The problem is, again, the patient selection within those studies. Some of them had underlying chronic disease and some did not. So it's important to understand these limitations, and basically there are high failure rates to consider. So whether or not you try it really depends on the experience of the team, the patient cooperation and tolerance of the therapy, and avoiding patients that are, for example, receiving vasopressors, that have shock, a low GCS, or abundant secretions. Now, in terms of non-invasive, I did mention that some patients may respond. However, delaying intubation in the patients that are not responding well, and I'll talk about how quick you should make that decision, delaying intubation in patients without previous cardiac or respiratory disease potentially increases their risk for mortality. So the longer you wait, the worse off you're making your patient. Now, in terms of what are some of the risk factors, severity of illness is sort of one that consistently throughout the literature, the sicker you are, the more at risk you are failing non-invasive. I think that one makes pretty much sense. Worsening infiltrates after 24 hours of non-invasive ventilation, but maybe that's too long to wait to find out when you have other things within 1 hour, such as heart rate. And you can see cutoff values here, 104, 144, and 23. So heart rate, PF ratio, and the bicarb after 1 hour are all sort of things that can predict failure. PF ratio I'm going to discuss a bit more closely here. So after 1 hour, they found a cutoff of 144, highly specific. These are just risk factors for non-invasive ventilation delivered to hypoxemic respiratory failure patients as well. And you can see some repeat offenders here with severity scores, age over 40, I'm now at risk of failing non-invasive ventilation. The presence of ARDS or community-acquired pneumonia is another one. PF ratio less than or equal to 146. So you can see this range of just below 150 sort of increasing your risk of failing non-invasive ventilation. And this is important. And that one scenario where I asked you whether or not you would adjust the ventilator or consider intubation, the answer is probably consider intubation. They had a high respiratory rate. Their heart rate was above the level that was mentioned here. I didn't mention they had pneumonia. That could have been, maybe someone could have asked me that, but I didn't spend too much time on the question. But the patient's PF ratio was 140. And often when we see someone on 50% oxygen, we don't often think, oh, that's a high level of FiO2, but it's the context of the PO2 they have. The patient's PO2 is 70. So this is a PF ratio of 140. Now, there was a study that looked at these variables after 1 hour. So taking this idea that after 1 hour, we should be able to see that there's a predictor of failure. This study looked at heart rate, acidosis, consciousness, oxygenation, and respiratory rate. And I'm horrible at acronyms. If they had me part of this study group, I probably would have named it Roach. And that's why they probably didn't have me involved. I'm also not from where they're from. But a Haycore score after 1 hour, greater than 5, had a diagnostic accuracy of predicting non-invasive failure that's pretty good. And it actually takes into account all the things I've already shown you as risk factors for non-invasive ventilation, and it just gives it a score. So heart rate, the level of acidosis, their GCS, the PF ratio, and how fast they're breathing. And I'll bring this up again in the workshop for those who are slow at taking pictures if you want. Now they found that the patients that after 1 hour did have a high Haycore score over 5, and they did fail non-invasive ventilation. The ones that were intubated earlier than the other patients, so within 12 hours or after 12 hours, had a significant difference in mortality. This is important. Again, do not delay intubating these patients. Now the role of tidal volume has been sort of looked at in the last few years, and this is the measured exhaled volume. I want to make sure I explain that clearly first, because with devices like the non-invasive devices that are standalone, like the V60, this is not what was used in these studies. They used ICU ventilators, and they measured expiratory tidal volume coming back through the ventilator. And what this group found was, of course, the usual offenders for association with failure: immunosuppression, low PF ratio, severity scores. But they found that minute ventilation and mean exhaled tidal volume during non-invasive also predicted failure. And they found that most of this was driven in the patients with moderate or severe ARDS. And the threshold for failure was a tidal volume greater than 9.5 mils per kilogram of predicted body weight. They did mention that this should be tested in an RCT. However, there was another analysis of the FRAT trial, which was a high-flow nasal cannula versus non-invasive and oxygen therapy trial, which I'll mention in a moment, where they looked at risk factors for failing non-invasive ventilation, and they too found a tidal volume greater than 9, so very similar, 9 mils per kilo of predicted body weight at 1 hour, and a PF ratio less than or equal to 200 at 1 hour. And of course, heart rate as well, and respiratory rate. Again, so things that are part of the Haycore score, as well as tidal volume, all predictors of failure in this patient population. So I encourage you to pay attention to these risk factors when delivering non-invasive ventilation, particularly in patients where there currently lacks a recommendation for that delivery. Now, for use in ARDS, this is data from another analysis from the LungSafe study. And they looked at patients with mild, moderate, and severe ARDS. And you can see a large percentage of patients received non-invasive ventilation. And when they matched the patients, propensity matched the patients with a PF ratio less than 150, you can see that nearly 50% of the patients in that category received non-invasive ventilation, and they actually had significantly higher mortality. So it's very important to pay attention not only to the patient, but perhaps the criteria of chest x-ray as well. And again, these are patients that do not have underlying cardiac failure, and more into the de novo category. So to generalize, use of non-invasive ventilation in this patient population of just looking at PF ratio, perhaps it's safe in 200 to 300 with a PF ratio. Less than 200, I would be a little bit more cautious. Less than 150, don't do it. And less than 100, what are you doing? The changing landscape. So most of the studies that I mentioned, the earlier studies, they compared non-invasive ventilation to standard oxygen therapy devices. And these devices do have many limitations, such as lack of humidification. If it's normal nasal cannula, the harder the person inspires or the stronger they inspire, the lower their delivered FiO2 is because of room air entrainment. And air entrainment devices like the Venturi mask, if you've ever played around with it, the higher the FiO2 you deliver, the lower the total flow is to the patient. And this, for any respiratory therapist in the room, this is derived from the magic box method of determining the total output of flow in these Venturi devices. You can see as you go up on FiO2, the total flow to the patient goes down. So which in fact makes the patients more hungry for air. In fact, I've been in arguments with COPD patients when I've increased FiO2 from 28 to 40, they argued that I turned down their flow. I turned down their oxygen. I said, no, I just turned it up. Look, the color's different on the adapter. It's higher FiO2. They're like, no, you turned it down. I'm like, no, I didn't. And you're like, oh yeah, they really are sensitive to flow. COPD patients, they love fans. If you could blow a fan on their face, all of a sudden their dyspnea just feels better. It's true. People are laughing because they're like, it's so true. All right. So high flow nasal cannula designed to deliver high flow humidified oxygen therapy. Large cannulas should not occlude the nares, but could fill a large portion of it. So make sure that there's a gap. And flow rates, depending the literature you look at, anywhere from 30 to 60 liters per minute. I would not exceed 60 liters per minute as it sort of starts to affect the humidification delivered by the humidity device. And just look at how happy this actor is. In terms of a PubMed search, again, if you look, you can see a huge increase that happened just prior to and around the time that this study was published by Fratt and colleagues in New England Journal of Medicine that really ramped up the use of this device and the literature published. They compared high flow nasal cannula with non-invasive ventilation and conventional oxygen therapy. Overall, their primary endpoint was reduction in intubation, which they did not see in the total cohort of patients with PF ratios less than 300. But in the subgroup of patients with PF ratio less than 200, they had significantly lower intubation and lower mortality at 90 days. So this was an important driver of the use of high flow. There's a number of physiological benefits. This is courtesy of Dr. Gallagher and Dr. Slutsky, published in the Blue Journal last year. Heated humidification of inhaled gas, washing out of upper airways, high nasal inspiratory flows, a little bit of positive airway pressure, and less entrainment of room air because you're meeting that flow demand. The patient's not pulling in as much room air, so you have more accurate delivery of FiO2. And all of this can lead to improved clinical outcomes. These physiological principles were also demonstrated in a paper by Tommaso Mari published in the Blue last year, looking at the physiological effects of delivering high flow nasal cannula compared to a normal oxygen face mask. And you see a decrease in the delta pressure, so the esophageal pressure we talked yesterday, so the swing in esophageal pressure was lower, the change in transpulmonary pressure was improved, pressure time product reduced, and a number of physiological variables also improved based on this increased patient comfort and including decreasing respiratory rate. So a summary of the clinical data for high flow nasal cannula include use in PF ratio below 200. Again, lower mortality and intubation rates in patients with hypoxemic failure, less than PF ratio less than 200. Post-extubation of low-risk patients. So in this study by Hernandez published in 2016 in JAMA, there was a significant reduction, although the reintubation rates were low, around 12%. They were 5% in the group treated with high flow nasal cannula directly post-extubation. So these were not patients expected to be at risk of failing extubation, but they did find a 7% reduction in mortality when using high flow compared to standard oxygen therapy post-extubation. And they did the similar study in patients with high risk. Now, this is difficult to define. There's a large list of what they considered high risk, but they found this was a non-inferiority study because it's already part of guidelines to extubate high-risk patients to BiPAP. So when you compare something that's a gold standard, you typically will do a non-inferiority study. And they found it not to be inferior, so about a 4% difference between the two. And you can see there's a separation at 24 hours because as per their hospital protocol, after 24 hours, they had to stop the therapy so that they could transition the patient out of ICU. So there's a separation here, but although it looks significant, it's less than 4%. It's less than 4%, and their non-inferiority category was 10% in terms of if it was significant. Now, again, looking at immunosuppressed patients compared to non-invasive ventilation, this is the intubation over 28 days. You can see non-invasive is higher compared to high flow nasal cannula, which is much lower. Where we also see some benefit post-operative cardiac surgery patients, there's a electrical impedance tomography study showing increased end expiratory lung impedance, better oxygenation and lower respiratory rates, but it didn't lead to other improved clinical outcomes. Where there seems to be no benefit is post-operative abdominal surgery. This is looked at in the OPERA trial, where they found no difference compared to normal care in terms of OR pulmonary complications. And this is likely due to the fact that when there's a degree of atelectasis that may be contributing to respiratory failure, they probably need a bit of positive pressure. And high flow nasal cannula probably doesn't deliver the amount of positive pressure required to have a positive impact. Where we are lacking data is patients with COPD that have acidosis. So in summary, this is my summary of guidelines or available evidence, including guidelines. It's just a little table I made up for a white paper. COPD and cardiogenic pulmonary edema still have the highest level of evidence. Where it's recommended, again, there's still recommendations for non-invasive, and there's increasing data that high flow may be beneficial. PF ratios between 2 and 300, I think either would be good in terms of what's available as sort of evidence-based practice. PF ratio less than 200, there's an increased risk here. However, there may be benefit providing high-flow nasal cannula. Community-acquired pneumonia, I put mixed evidence here. I showed you risk factors for failure. I do want to point out that in the FRAT trial, about 78% of the patients had community-acquired pneumonia, and there were beneficial outcomes. So I'm not saying this is not part of any current guidelines. There are no current high-flow nasal cannula guidelines, so this is all based on my review of the literature. Post-extubation in high-risk patients, immediately post-extubation, recommended. Post-extubation to early liberation of COPD patients, recommended non-invasive. We don't have data for high flow in these patients. And post-operative patients, it's inferior to non-invasive ventilation. So I'm going to leave with this as my last slide here, just a reminder of the risk factors and signs of failure. If you like taking pictures of slide, this is one I think that's very important, specifically if you're providing non-invasive ventilation to patients who don't meet the strong clinical recommendations right now. So more specifically, the de novo hypoxemic respiratory failure population. So older age, yes, over 40, as sad as that is to say. Level of consciousness, high severity scores, use of vasopressors, presence of ARDS or community-acquired pneumonia. And I've separated this to sort of what the patient is like, medical condition, some respiratory parameters, monitoring parameters, and then response to therapy. I think that's it. I think I did that in there. A lot of time, not too shabby. I have some time for questions. Thank you. Time for a few, yes. There's varying degrees of PEEP described. It depends if your mouth is shut or open. That's part of the problem with saying exactly what it provides. I've seen 3, I've seen 6. It depends on your flow rate and whether or not your mouth is open. So it shouldn't be looked at as a device to deliver positive pressure if you think that's what the patient needs, which is probably why it's sort of fallen short in providing good outcomes or a difference in patients post-operatively, specifically the abdominal surgery population where they likely have some post-op atelectasis that's probably not gonna be totally maintained or improved with use of high flow. So yeah, it's low, it's not the same. Yes, Baya.
Do you have any thoughts with regards to use outside of the care section specifically or step down, step up?
Yeah, if you have step up or step down units, I think this is a really excellent place for non-invasive ventilation because you do typically have slightly more monitoring and the patient may or may not require ICU. I think if you're utilizing a step down unit for a COPD patient requiring non-invasive or a cardiogenic pulmonary edema, some of these patients may be managed well in the emerge department, but the step up or a step down unit would be ideal for that. For de novo hypoxemic respiratory failure, I think this is probably a bit more risky to use a step up unit or a step down unit, particularly because let's say you've started non-invasive ventilation, you should within 1 hour make a decision to escalate it to ICU or not. And does that happen always? Probably not. And I see you shaking your head no as well. And again, I think it might be due to people not really being aware of the well-established risk factors in the literature, and maybe they're not looking at all of them. Maybe they're just looking at one of them and saying, oh, my patient's still okay. But delaying that intubation, I think, is important to avoid. And yeah, you may actually prevent a worse outcome if you use an ICU for those types of patients. Yes?
Did you in your travels see any information about the pediatric population for non-invasive high flow?
So there's actually quite a bit of published data in pediatric patients with high flow. Argumentatively, that's sort of where, if you look at this spike in the literature, prior to 2015, it was mostly driven by neonatal and mostly neonatal population. But there's